Please join us every week for a new episode of Understanding the Human Condition with Dr. James Flowers. Dr. Flowers and his most admired mentors, respected colleagues, and VIP guests will share valuable insight into underlying health causes, conditions, and issues. These in-depth yet approachable episodes are a great resource for both private individuals and industry professionals. Our esteemed host, Dr. James Flowers, is one of the most recognized and respected names in the field of chronic pain, mental health, and substance use disorders, both nationally and internationally. Dr. Flowers is the founder of J. Flowers Health Institute, located in Houston, Texas. For more information about J. Flowers Health Institute and its concierge services, go to jflowershealth.com or dial 713-783-6655. And be sure to mention this podcast.
Welcome, everyone, to Understanding the Human Condition with our host, Dr. James Flowers.
Hey, Robin.
How are you?
Good. How are you today?
I'm very good.
I'm super excited. My good friend, Dr. David Lee from Hattiesburg, Mississippi. In his bio, Dr. David Lee is a distinguished ABNS board-certified neurosurgeon in Hattiesburg, Mississippi, with over 20 years of experience in working with patients. He is a fellowship-trained spine specialist and currently with Southern Bone and Joint Specialists. He is very active in the management of chronic pain, which is how I know Dr. Lee, and is a consultant for several companies who manufacture devices that treat this condition. Dr. Lee has several patients. He has a lot of patients as well. Oh, patents. I was like, patients. Dr. Lee also has several patents. Dr. Lee, welcome to Understanding the Human Condition.
Thank you. Well, I had a question for Dr. Lee about one of those patents. How many patents do you have, Dr. Lee?
I've got one right now we're writing up, and there's, I think, 5 other ones that are all spine devices.
Because there was one that I was reading about. It's a machine that provides spine surgeons with a test that's 79% more accurate than the typical MRI machines, and it also reduces cancer-causing radiation exposure. Now, that was something from a few years back, so I'm sure it's like,
Yeah, a lot of those, most of the things that we're developing now are mechanical type implants and things of that nature. Like I said, I spend all of my day treating spine patients now. I quit doing cranial surgery a few years back, but I did my fellowship in spine after doing my residency in neurosurgery. So, we focus all our time and energy on spine. I've got some physician assistants and nurse practitioners who work with me. Then I'm in a big orthopedic group here in town where there's 14 or 15 orthopedic spine surgeons in our group, and then we have neurology, physiatry, and all the ancillary services as well as a big surgery center. So. We kind of try to provide comprehensive, bone and joint care, so to speak. But my focus is entirely on spine.
Yep.
In the event there's someone listening who doesn't know what a neurosurgeon is or does, can you explain that to the audience?
Yeah, I mean, neurosurgery is a field of medicine where we're focused on both operative and non-operative treatment of the conditions related to the brain and spinal cord and spine and peripheral nerves. And so, it may be something as simple as a carpal tunnel release that we do routinely versus, taking a ruptured disc out of your back or fixing a neck fracture. Those are things we do routinely. In addition, once again, the majority of the people who do it are still practicing cranial surgery. So once again, if you have a brain tumor, if you had a stroke, things like that, we deal with diagnosis and treatment of those conditions as well. So it's a pretty broad field as far as there are people who specialize in movement disorders that treat Parkinson patients for tremors. There's, you can get very specific into subspecialty areas of neurosurgery. There are certain doctors who are only pediatric neurosurgeons, and ones who do just spine, and ones who do, tumor and vascular surgery like aneurysms and things like that. So it's a broad field. It's as opposed to neurology. Neurology is more of the treatment of headaches and seizures and doing things like that. So it's kind of a different spin-off. But we do a lot of operative treatment, but we also see a lot of non-operative things as well.
Yeah, absolutely.
And you do a lot in sports medicine with. Can you talk a little bit more about that too?
Yeah, we've got some things that we're working on as far as products related to like a pre-concussion cream that you would apply topically to the carotid arteries that provides you do it before any type of contact sport in case you took a head, either concussive or subconcussive blow to the head. it's like an anti-inflammatory effect to kind of lessen the injury to the brain. I'm also involved with a company that's producing a neuropeptide that you would be inhale it like a nasal spray that would actually help treat concussion.
Interesting.
Brett Favre and I are both involved in those two companies. Brett's from Hattiesburg as well, or lives here in town, and we'll probably have him on a subsequent visit. But he and I both work with these two companies. They're kind of related companies, but separate in other ways. But he and I are both on their advisory board for those type products.
You bet. You and I worked together and had a multidisciplinary chronic pain program. So for patients that you were seeing, a lot of your patients, obviously, with spine difficulties and the work that you do on the spine, a lot of patients have chronic pain prior to coming to see you, and then sometimes come in with severe depression, severe anxiety, fear, grief, avoidance, somewhat of a poor attitude, saying, I'll never be able to accomplish anything again. How do you think psychology fits into your practice and in the world of chronic pain, treating a chronic pain patient?
This is something I see every day. Every day of the week I have to deal with chronic pain. But, in my practice in particular, I do most of this area's spinal cord stimulation. And so I'm seeing the worst of the worst when it comes to the chronic pain patients. And like you said, just take a typical, like an injury of any type. It doesn't have to be a work comp injury. It could be any type of injury. If you look at the pathology and then what happens afterwards for the psychology of it, initially, to get not too technical, a stimulus is applied to a nociceptor. A nociceptor is just a cell or receptor on your body that registers whether it's pressure, temperature, something that's a noxious stimulus. And then those signals get transmitted from the nerve through the autonomic and the central to the spinal cord of the dorsal columns. And then that information is relayed to the thalamus of your brain, which is part of your the deep brain, and then it's sent to several areas, including the limbic system. The limbic system is the emotional center of your brain. And so all these areas kind of tying together, there's the physical contact that causes the stimulation, but then there's all this cascade of things that get set into motion. And then, take the typical person who gets hurt, they hurt their back on working offshore.
Right.
They get sent home and, they can't go back to work within 2 weeks. They get an MRI scan, they're put on narcotics, they're given anti-inflammatories, they're given ice packs, things like that. And then they don't get better. They're getting paid not to work. Right. So there's a secondary gain issue right there that they have off the bat. And then because they're hurt, their wife or husband says, well, you can't mow the yard, you can't take the kids to school, I'll do that. So they become less involved. The less active they get, you don't get an endorphin release because they're not exercising. So you get a little bit of depression builds up. Then you have to get a lawyer because you can't go back to work. And then this cycle gets set into play where, there's so much emotional component to it. You no longer have just that physical stimulus that causes the receptor to be activated, but you've got this entire cascade of psychological things, whether it's secondary gain. And secondary gain is not just intentional, it's subconscious. I mean, you can't help but get depressed, withdrawn, and then you focus on your pain at that point. And then you catastrophize. You feel like everything is magnified because you have nothing else to do. And then you throw on top of that the opiates, and then the more you take, the more the receptors, get blocked, and you have to take more of them and things like that. And it's just this vicious cycle. You have to intervene at some level, which is what we try to do. With some of these people, you have to get them into a psychiatric program or psychology program just to break the pain cycle so that you can actually start to heal.
That's exactly right. And that's that program that he and I did together. And, patients would come 8 hours a day, 5 days a week for 20 to 30 days at a time. And when they came in, take the Beck depression inventory, the Beck anxiety inventory, people would score severe depression, severe anxiety, severe avoidance, a lot of secondary gain issues as well. And like Dr. Lee said, not all of it is intentional. A lot of it is behavioral, right? Or the wife or the husband says, let me do the dishes or let me do this for you. And it kind of becomes a habit. And all of a sudden their body begins to atrophy, their mind begins to atrophy because they're not having to work, they're not doing anything, and they get in this cycle and their life just starts to spin out of control. And they think that an opiate or a surgery is going to help them. And knowing Dr. Lee for as long as I've known him, he's not going to do surgery unless it's necessary. He did surgery on my father-in-law just, I think, a year ago or so. and then saw him again recently, and he came in. I think he had an L4, L5 disc herniation. Dr. Lee ended up doing a fusion, I believe. He's doing well now. He had foot drop. He's exercising. He's going to physical therapy. But, here's someone that has worked in the forest, cutting down trees for 60 years of his life, right? And worked outside, and then he had this chronic pain. And it's someone that isn't depressed, but pain will make you depressed. And you think, oh my gosh, I have to have surgery. And many times surgery is appropriate, but it's not always appropriate. But for the patients who you and I both see, and we've seen for years, and we're in the middle of this opiate epidemic in the country, take apart COVID that we're going through. We have this other huge epidemic that we see, and that's the opiate crisis. And people who have experienced hyperalgesia need more and more and more to have the same effect on them. Part of my lecturing around the country when I'm talking about chronic pain and culture, there is an absolute cultural difference between different parts of the world. And I always ask my audience, I practice mostly in Houston, Texas. Houston and the 3 counties that surround us have about 8 million people in it. I've been practicing here for about 29 years. And I always ask the audience, how many Asian patients do you think that I've seen in my practice? And they're like, God, hundreds. Houston has a huge Asian community. I've treated less than 5. Yeah, less than 5. And you are exactly right. It is, I need it now. I need it fixed now. I want to know how to fix it. You're a physician. I need you to fix it for me. And I need to feel better today. And so many times that first answer is and you guys are so busy in your jobs, and these patients come back and they come back and they come back. But around the country, what happened is Joint Commission actually said to hospitals, if you don't treat pain adequately, we're going to take your Joint Commission accreditation away. So that opened Pandora's box and said, oh my gosh, we have to prescribe medications. And it really just opened this whole epidemic up when Joint Commission did that, after, not to be political here at all, but I think with good intentions. But President Bill Clinton in the 90s named the 90s the decade of pain. And he signed into law that you must treat pain adequately. Not you should, but you must. And when that becomes part of Joint Commission and then it becomes part of the law, and your patients are like, I'm on that scale of 1 to 10, I'm a 10, then write me a prescription. And that's what happened in the hospitals that in the hospital systems. And, post-surgery now, speaking of my father-in-law over in Mississippi, my mother-in-law had a quadruple bypass surgery. And I think it was 2 hours, maybe 3 hours after surgery, she was walking loops around her floor. And they were making her get up and walk and hold a pillow. And she did it. But years ago, it was like, let's stay in bed. And if your back is hurt, Dr. Lee, my grandfather was a surgeon. And when I was growing up, he would tell patients with back pain, lay down and rest, and it'll get better in a week or 2. That's the worst advice you would give today, right? We need to move, and we need to oil our backs and keep busy and keep moving. So,
it's funny though that in the Clinton years where and the Joint Commission putting out that you had to treat pain, and you had this pendulum shift where everything swapped over to you got opiate for anything, and you could. I've seen people that are smiling saying they have a 12 out of 10 pain.
Yes.
And then they come in, they're on 30 milligram oxycodone tablets 4 times a day, and they walk in smiling and they don't have a limp. And then all of a sudden, this everything shifts to where now, I hate to say it, but now pain is probably undertreated because the pendulum has gone back the other direction, and you're almost criminalized if you ask for pain medication now. And particularly the ones that get harmed are the ones who've been on it so long that
That's right.
they really need rehab to get off of it, rather than cold turkeying it. So you have to be careful what you wish for, because it's really, it's just that paradigm shift over that rapid of a period can be dangerous too.
I
because
agree.
People get undertreated to some degree.
That's right. And the pendulum that you're talking about, I always talk about in my lecture that many physicians went from opophilia to opophobia, right? And saying, I'm not going to prescribe these medications. I will not do it. What advice would you give chronic pain patients today that, yesterday I spoke with a woman in Dallas, Texas, who she has a herniation at L4, L5, and I forget what was wrong with S1, but L4, L5. And she asked who the best neurosurgeon in the country was. And I said, well, if you're able to travel to Mississippi, you need to go see David Lee. But what advice would you give someone today that has ongoing chronic pain and hasn't felt that relief yet?
Yeah, it really depends upon the problem, because, if you've got a deficit of some type, say you've got, a pinched nerve and you're developing a foot drop like your father-in-law did. I mean, that's something that has to be, you probably need to have that fixed, and you can work those things up and figure out where you are on the scale of needing surgery based upon typically an MRI, myelogram, and an EMG, like a nerve conduction test. But, for somebody with chronic pain, I see people in my practice every day who've had hip surgery, knee surgery, ankle surgery, back surgery, and they're just not better. And they're not asking for narcotics. They're wanting to get off the narcotics.
Right.
And so, there are options for people that have those conditions. And typically you're diagnosed with it used to be called what's called a complex regional pain syndrome. Now we see a lot of those people that have it. We offer spinal cord stimulation. There still are some opiate people who place opiate pumps in place so you don't get the euphoria and you can still function, but those aren't near as common. But the spinal cord stimulators are a really good option for people. They're minimally invasive, and you try them first. You don't just implant an $18,000 battery. It looks like a pacemaker battery, and you'll go in and do a trial. So there's certainly options for people with chronic pain, whether it's from joint pain, back pain, some type of nervous condition or nerve condition. So those are certainly options, and find a reputable, either a neurosurgeon, orthopedic spine surgeon who deals with chronic pain patients, and at least get an evaluation.
That's right. Absolutely.
Well, I can't believe this, but our show we've been given the 2-minute warning, unfortunately. So we'll have to pick this back up again.
Yeah, I was beating my hand on my head trying to think what CRPS. It was RSD. Reflex sympathetic dystrophy. Yeah.
Right.
And then they moved it over to CRPS, complex regional pain syndrome. You're amazing as always. I can't wait to get over to Hattiesburg.
I can be reached at Southern Bone and Joint Specialist, PA, here in Hattiesburg, Mississippi. We've got a website. Okay. And you can book appointments and things like that online.
That's great. And we will put that information on our website at jflowershealth.com. And you can reach us at jflowershealth at 713-783-6655, or again, jflowershealth.com.